Ευχαριστώ Γεωργία που με καλέσετε και την επιτροπή σας. Ευχαριστώ Professor. Έχουμε και το πρόεδρο του European Society of Pediatric Radiology μαζί μας και είμαι πολύ ευχαριστημένος που με καλέσετε και είμαι πολύ impressed, πώς το λέμε, που έχετε παιδιατρικό συγκέντρωση. Είναι πολύ μεγάλη πρόοδος για τη χώρα σας και πώς έχουμε το subspecialty μας εδώ προχωρά. Από τώρα και να πάει όλα στα αγγλικά, σας παρακαλώ. Το πρώτο πράγμα, αυτό είναι μόνο delayed MRI. Θα μιλήσω μόνο για το delayed MRI και θα μιλήσω μόνο για term hypoxic injury. No premature injury in this talk. And why? You will see that I have a bit of experience with term hypoxia that is a little bit different to what you are used to. And the imaging is different what you are used to because you want to do the imaging early. Because you want to have prognosis, as you say, you want to predict, but you also want to make early diagnosis. Maybe you have cooling and therapy. So let me get on with it, and we can see. So for young people in the audience, just as a general rule, the first rule I follow when I look at an image is that if it's a global insult, your whole brain suffered from too little oxygen or too little blood, then the whole brain has been subjected to the injury, the insult. And the injury will represent itself in places that are most susceptible to the injury. And therefore, the injury will usually be bilateral and symmetric. And that's the first rule. So you have two pictures here. One, you see injury that is bilateral and symmetric. And one, you see injury that is unilateral and follows one arterial territory. So very simple. If it looks one side of the brain, fits to the middle cerebral artery, that's a stroke. Okay? If it's bilateral and symmetric, you can start thinking about a hypoxic injury. And we will discuss the distribution of that next. So you can teach hypoxic ischemic injury in one slide, and I will try and do that 2 slides for you, and then we'll discuss other things. So, as I said, you put the brain under too little oxygen, too little blood supply, and the part of the brain that suffers the most is the following. The bits that are having a lot of demand for oxygen. So in children that are term, it's the myelinated or myelinating areas. And therefore, if you listen to the talk, an image of what should be myelinated and what should not be myelinated at term, very important. So the posterior limb of the internal capsule should be myelinated from 38 weeks. So you know that's an area you should watch for a patient who has suffered a hypoxic injury. Areas with the worst blood supply. So you have 3 big blood vessels in the brain. It's like maybe your internet service provider, I don't know, ΜΗΤΕΡΑ, whatever you have. If you're at the end of the road, at the top of the hill, you get the worst. Unless it starts from you and goes down to the sea. Whichever way, the guy at the end gets the worst. It's the same with the blood supply, but you have 3 blood vessels. So at the end of 2 blood vessels is probably the worst supply. We call it the watershed. And these things vary with your maturity. So a term injury, and that's why I'm making a big deal about that. I'm going to talk about term injury is very different from premature injury because your watershed is different, your susceptibility is different, what is myelinated or not myelinated is very different. And lastly, the severity. So these are all the things that play. So if you have an injury that's sudden and complete, it looks different to an injury that's been going for many hours and you're having a prolonged delivery and labor and whatnot. So I'm going to show you 3 pictures, and it's very simple, and after that we get to the business. This is term hypoxic ischemic injury pattern involving the deep nuclei. We call this the central pattern. Some people call it basal ganglia thalamus pattern. And very easy to remember, and people used to say this is what happens when you have acute profound injury. Sudden, complete stop of blood supply, okay, or complete sudden stop of oxygen to the brain. And you will see the areas involved are the putamen, especially the posterior putamen. You can see a little white stripe. And in the thalamus, the ventrolateral nucleus. It means anterior and lateral, as you can see with the 2 bottom arrows. The other type of injury is a watershed injury or a peripheral injury affecting the cortex and the white matter. So that's it. These are the 2 main patterns. And of course, you can get both. So some people will have If this was the same patient, it's not the same patient, but if it was the same patient, the lower slice would look like that, and the upper slice would look like that, and you can have both together. We call it combined. And one last picture I'm going to show you, and we'll talk about it right at the end very briefly, is this multicystic pattern. This is a catastrophic insult. Some terrible thing happened, an abruption of placenta, a lot of bleeding, a lot of blood loss. Something bad has happened to this brain, not commonly seen, but there's some unusual things relating to this that I will talk about. So I will come back to that at the end. So we could stop here and you could walk out and, you know, okay, if I see posterior putamen and I see ventrolateral thalamus, this is highly possible in the right clinical setting that was an acute profound injury or a basal ganglia thalamus pattern. And if I saw a watershed injury, you can tell did something happen over many hours, and you can have that discussion and look at the history and whatnot. So before I move to things, there's a bit of a problem in that this can also happen. These are two separate patients. You can see the basal ganglia are involved. Not exactly just the posterior putamen, but the caudate nucleus and the putamen. And if you look higher up in this child, you can also see the watershed. These are diffusion-weighted imaging. So it's been done. You know the injury happened recently in the last few days. Okay? But this patient is not a term newborn. This is a patient, sorry, let's do the other one. Very similar pattern, very similar ADC, DWI, deep nuclei, and watershed. This one is a 5-year-old who had a cardiac arrest. And this is a 7-year-old who had a prolonged seizure. We did the scan the next, whatever, in the evening. And this is the picture. So basically a term injury, and for the rest of your life looks the same. Okay? It's not the same as premature injuries, which look different to anybody else. Okay. So term hypoxia looks like a 5-year-old, looks like a 7-year-old, maybe a little bit more basal ganglia involvement, but very similar. So the ideal imaging is to do the early imaging with diffusion. And a lot of people will show you this lecture with the diffusion, the watershed injuries, the deep nuclear injuries, and you will have a lot of benefit if you do this in your work environment. I'm sure you have it. I'm sure you do it here. You get the early diagnosis. You can start cooling. Get the cooling, kind of the cooling. Yeah, you do the cooling. It helps. You can time the injury. If anyone's asking when did this happen, well, in the last few days, the baby was just born. We did it today. It means this happened, you know, yesterday, this morning, whatever. And you can predict prognosis. So, as you say, you tell the parents things have gone badly, the deep nuclei are gone, what to expect. And there's a lot of scoring systems and a lot of teaching about this. But there's a few things that I think are not said. There's many countries that cannot give you an MRI scan on the same day. There's many countries that don't have an MRI scan for the week. And there's many countries that cannot give you an MRI scan at all. But I'm talking about many countries. You're in the middle of Athens. At ΜΗΤΕΡΑ is your premier private practice here. I work in Children's Hospital Philadelphia, #2 in America, you know, #1 in America. And these are places you can get an MRI. They don't even ask the doctor. They just book the MRI. It comes up on my list. I read it. You know, in England, you have to ask the radiologist. So, valuable for prediction, but you actually don't know what the outcome is going to be. You're predicting. And secondly, many countries don't have the MRI. So there's a lot you can learn from countries that do MRI late. Okay? And why you want to look at late imaging? I don't think the early imaging is that accurate as you want it to be for a number of reasons. Okay? So if you don't do the MRI scan at the right time. Okay? So this isn't a talk about timing your DWI. I don't want to do that talk. But if you do the DWI at the wrong time, you get pseudo-normalization. If you do it at the wrong time, some things have reversed. Or if you do it at the wrong time, some things have not reversed yet. Okay? So there's temporary damage that you think is permanent, but it's not. Okay? There's subtle things. So DWI is not the same as a flare. It's like the resolution's not the same. The contrast is not the same. So when things look fantastic on DWI, it's great. But often DWI doesn't look like what you want, what we show you in the pictures in your talk. And the posterior fossa, you think you get good results, but DWI, and especially the ADC, has a lot of challenges in your posterior fossa. So a lot of cerebellar injuries may be missed. And the most important thing I want to tell you today is that if you injure the cortex today in a child, over the next months and years, everything connected to that cortex, your connector, what we call your circuits, all die. Not everything, but a lot of them die. It's called pre- and post-synaptic injury. And I was a terrible student at school. I don't even know, where your corticospinal tract goes. But I have to know now, because if you have a watershed injury on the surface, you can expect a lot of injury to happen along the tracts. And those tracts sometimes go through your nuclei, such as your thalamus, your dentate nucleus, and other structures. And that's what you're sometimes calling Wallerian degeneration and atrophy, but it also has signal. And a lot of that didn't happen, and you can't see it on the early DWI, so your prediction is not necessarily accurate, okay? So where does our experience come from? Okay, I told you I come from America, but actually, είμαι Κύπριος, που πήγαμε στην Νότια Αφρική, okay? So in South Africa, things are very different, a lot worse than what you know in your peripheral areas. Here, even on your islands, we have places with nothing, okay? When a child has a hypoxic event, they don't tell them anything. They don't tell the mother anything. If it's in the village somewhere, they have one obstetrician or maybe no obstetrician, some doctor, some nurse delivers the baby, they have a prolonged labor, or they were having tea while the baby was being born and they didn't come and look. And the baby comes out abnormal, and then they say, you must come to the cerebral palsy clinic with your baby. And we have tons of children in cerebral palsy clinics that live like this. They go back to the hut. There's no road, there's no running water, there's no electricity. They give them a wheelchair, and they sit in the chair. And then come and see us at the cerebral palsy clinic. Nobody says to the mum, look, somebody wasn't doing this delivery correctly. Somebody wasn't watching. Nobody has had a tachograph. And this is not just happening where there's no help, because when there's no help, well, nobody's to blame. This is also happening in hospitals, in peripheral areas, which are not staffed properly by the government. So, 90% of mothers in cerebral palsy clinic did not get told their child has a hypoxic event for the cerebral palsy. Nobody looked to see what is a cerebral palsy from. Okay, so the cerebral palsy means nothing. It's a dustbin. You put everybody that has some problem in there. Some are hypoxia, some are white matter disorders, some have got other things, okay? Some had hypoglycemia, whatever. The incidence in the normal world in the literature of cerebral palsy is 2 to 4 per 100,000. In Africa, whoever wrote the paper says 10 per 1,000 live births. But it's much, much worse in reality, because nobody's told them, okay, what's going on. There's people hidden that don't go to the cerebral palsy clinic. They just leave the child in the bed at home. And this is especially for remote areas with scarce resources, and almost nobody has an early MRI scan. So where do I come in, and why do I know so much about these things that I'm going to show you? Is I've read 2,500 scans actually climbing, so the research you'll see is on 1,000 patients, then on 2,000 patients. Medical legal cases, lawyers go to the cerebral palsy clinic and they find the mums and they say, σου είπανε τίποτε, τι έγινε με το παιδάκι? Όχι, έλα σε εμάς και τους φέρνουν και τους κάνουμε ένα MRI. Okay? Εγώ κάνω μόνο τα reports. I don't have a practice, I just read the reports, I have a small fee, and the lawyers take them to court. If they win, they give the family money, they keep some money and whatnot. It's also a racket. You know what a racket is? Είναι και μία μαφία. Έχει μερικούς που είναι φυλακοί τώρα, αυτούς τους δικηγόρους. Και μερικούς που έχω βοηθήσει εγώ και νιώθω άσχημα. Okay? Anyway, what I've done with the information, I collected a lot of information from this, which I'm sharing with you today. So early MRI looks like this. Here's your DWI. Late MRI looks something like this. Okay? So why is the late MRI an advantage sometimes? And this is what I want to show you. I think the late MRI can tell us a lot. Okay? So one, I'm using FLAIR T2. It's not just signal. It's not just signal on a bad sort of grainy DWI image, even though a lot of our DWI now has improved, looks like a T2, but it's not a crappy image. You get a great FLAIR image with gliosis, okay, or spongiosis, whatever you want to call it, this bright signal, but it's accentuated by atrophy. So wherever you have the signal abnormality, you also have volume loss, and very easy to see. So the watershed is suddenly now very visible. And if you are seeing any of these kids with MRIs, you will be able to see the watershed with a lot of ease, which has helped me map the watershed. So, is more conspicuous injury on T2 and FLAIR, Everything that's reversible reversed a long time ago. These are 5-year-old children, 6-year-old children, 10-year-old children, even older adolescents. There's no problems with timing. You can do it any time after the first few months. Bring them when they're 2, bring them when they're 10. It's permanent scarring in the brain. And it's ideal for determining what the full distribution, the full extent, including any secondary, post, and pre-synaptic injury to your circuits. Okay? And I'm not even mapping it using DTI. I'm just looking at signal. Okay. So there's a ton of papers we've written, all on delayed MRI, so people are suddenly interested because we're showing some things. So some things are not going to interest you so much, you say, I knew that, and other things might interest you because you probably didn't know it, okay? So one, nobody looked at the watershed in kids. There's no map in the literature that goes, we have mapped the watershed, it's over here. Why? Because the watershed is an imagined place, right? It's where the vessels end, so you should know that point where they end, that's the start point. But the degree of the hypoxia affects how much of the watershed and how much of the normal brain you extend into. As a matter of fact, some of these patients have their whole brains affected, both sides, you know. So you don't see a watershed, you just see generalized atrophy. But we took a whole lot of brains that had watershed injury, and we took a pen, and we drew around the signal, 3 of us together, and we mapped it. In adults, they have good maps because they have stroke. And they go, this is MCA, this is ACA, this is PCA, and they said, okay, well, between that, that's the watershed. You know? Anyway, so we did that. This is what it looks like. And I'm going to just show you, this is a frequency map. Out of the children involved here, where you see red, all the children had involved. Where you see blue, some of the children had involved. So the areas with red are the important areas. This is the area everybody has, okay? So the anterior watershed is there. And if you look, it's right at the anterior sulcus, okay? The frontal sulcus, okay? Around it. Then if you see over the top of the brain, along the falx, okay? A lot of people talk about parasagittal. That means away from the midline. But there's a lot next to the midline, next to the falx, okay? And then if you look at the next set of arrows, there's a lot going on next to the Sylvian fissure. So we call it perisylvian injury. And then there's this occipital, which is the posterior watershed. But if you'll notice, the red stays away from the tentorium. And I will show you better pictures of that as we go. So the distribution was not defined before. We define it for you. Now, I have some special tips, advice. The anterior watershed is centered around the superior frontal sulcus. You will always find atrophy there around on either side of the superior frontal sulcus. So this is the anterior watershed, if you want to give it a name, okay? The posterior watershed, you know, some of these are involved in continuity, but sometimes you just get posterior. Sometimes you just get anterior. It's susceptibility and how your body was built. The important part about posterior watershed is you always get sparing of cortex just above the tentorium. Hardly ever involves that little strip above the tentorium. And then you realize, oh, this is not an occipital injury, this is a watershed injury, we spared a little bit. And the same is true for this perisylvian injury. So perisylvian should be the most involved because it's where the 3 vessels have their worst supply, at the end of all 3 vessels. And it should be this area that's atrophic here, okay? Right at the back of the Sylvian fissure. But in fact, it extends all the way forward. And the one thing I can tell you, I'm going to compare a perisylvian, severe perisylvian involvement and anterior, but severe perisylvian involvement. When you look at the sagittal image, okay, we're going to compare that area to a patient who had a stroke as a child, perinatal arterial stroke. You see that the superior temporal gyrus is almost always preserved, okay? In a watershed injury, it's often involved in a stroke. Okay, when you look at a picture, you want to go to Radiopedia, you want to go to a textbook, and you say, show me watershed injury. They show you 2 triangles in the front and 2 triangles in the back. And of course, when we look at our DWI, we see 2 triangles in the front and 2 triangles in the back. But in fact, it's a band from the front all the way to the back, and not just the surface, including the white matter underneath it. It's a thick band, as I've shown you. So it can be a continuum, right? Extending from front to the back, sliced down into the depth. So to show this band, we took the brain and we did what you do when you make a map. So if you look at the globe of the Earth, but you don't look at the globe when you want to see where you want to go in Glyfada to swim, you take a map that's flat, So somebody took the circle and they made it flat into a map. So we did that with the brain. This is a normal brain. The eyes are on the side, the temporal lobes are sort of on the side there, and you can see your parasagittal area. If you flatten a child with a hypoxic injury, you can see all that atrophic area in a band and a band, okay? So you can involve the whole watershed, portions of the watershed, in continuity, separated from each other, many patterns. This is something important that I want you to remember. If you walk out of here and you don't like anything I said because it doesn't interest, or we never do these late MRIs, so what? I like this. I'm going to show you a sign that tells you the injury happened perinatally from a delayed scan. Very important because I have to go to court. Okay? And the guy says, well, how do you know he didn't have a prolonged seizure at 7 years? How do you know he didn't have a cardiac arrest at 5 years? How do you know he didn't fall into a swimming pool? How do you know this was perinatal? So this is how you do it. Okay, so not a lot of people know about it, not a lot of people talk about this, and not a lot of people write about this, okay? So this is a normal brain. The circle is where you expect the watershed in a coronal view, okay? Well, of course, we can have the parasagittal bit. You can look at that as well. Here's a patient with a watershed hypoxic injury. You can see the atrophy in the areas parasagittally, okay? So it's the anterior watershed extending posterior. You can also see next to the falx, if you use my mark, you can see there's atrophy next to the falx too, right? Compared to that. Okay. So what I want to teach you is about the gyri. Okay? Now, if you look carefully at the gyri, this gyrus with the white arrow, you see what's happened to it. The base of the gyrus is thin, and the top stayed thick, like tokotobolo, postoleme, to drumstick, to Kentucky, after, egenesan after. Okay. So what's happened? The bottom shrank, so the stem of the gyrus is thin. Next to it, you can see the sulcus, instead of being straight, is now a teardrop, saragrio, okay? And if you look at the normal, it should be thick at the bottom and a completely straight sulcus, CSF in the sulcus, okay? So this is called eulogyria. I don't know what it means in Greek, eulogyria. I think it's Latin, right? Mushroom, then it's the Latinica. Ah, bravo. Ah, bravo. Okay, scarred gyri, perfect. So it's very important for me because when I get a brain that looks like this, you say, possible is not in a watershed. Where's the watershed here? The whole brain is atrophic, right? Like there's atrophy everywhere. There's hardly any white matter. Look, the ventricles have expanded out to take the space. If you find the eulogyria, you know it was a hypoxic event. And so that's the first thing. So you convert your just atrophy to hypoxic, atrophy after hypoxia, but you also say this happened near the birth. Now, it's not that accurate. It's not only the first week. It's up to 2 months, okay? But at least when he goes, did the child fall into a swimming pool at age 5 years, you go, no, this happened around the birth, the time of the birth. Very, very important. We've published that. It's accepted. People knew about it. They just don't use it because everyone's interested in acute imaging in DWI. What about the deep nuclei? We can just stop there. Okay. The deep nuclei are different too. So we compared the children with pure basal ganglia thalamus with the ones who have combined watershed and deep nuclei. And you'll realize that the deep nuclei involved when you have watershed are not always a combined hypoxic pattern. Very important because they want to say, look, it happened very quickly, very suddenly. They couldn't send for a doctor, nobody's to blame, you know, the doctor was somewhere else. By the time he came to do the cesarean section, the patient was. But in fact, the deep nuclei are involved very differently. So in pure BGT, okay, you always see putaminal and ventrolateral nucleus like I showed you. But when you have watershed and deep nucleus, the majority is involvement of the thalami and hardly ever involvement of the caudate nucleus. So that thalamic involvement means, wait a minute, is this truly combined, right? Acute, profound, and partial prolonged in the same patient? Or do we have thalamic injury from something else? So why? Maybe the pre-existing watershed modulates how the deep nuclei are susceptible. I think that's garbage. You know, they're susceptible, they're susceptible. Maybe you've got hypoglycemia. They were in labor for so long, they ran out of glucose, and that's why the pulvinar is involved. Or maybe it's all part of the circuit injury, right? I'm seeing these patients late, and the thalamic involvement is probably part of the corticothalamic cerebellar circuit injury. And this led us to investigate the thalami further. We divided the thalami with a protractor, and basically looked at all the BGT pure, and we looked at all the patients who had also watershed and deep nuclei. And basically the conclusions are, as you see here, the patients with watershed injury, the thalamic injury can be medial, can be pulvinar, but rarely is it ventrolateral. The BGT is always ventrolateral. It's hardly ever medial and posterior. Sometimes the whole thalamus is involved, and then you have no answer. If you want to see the odds ratios, the BGT alone, it's 7 times more likely that you have a ventrolateral nucleus involved. When you have watershed injury, it's 20 times more likely that you have the posterior or the pulvinar nucleus. So basically telling you that thalamic injury is not always part of BGT. Thalamic injury can be the cortical network injury. General distribution, I want to talk a little bit about cerebellar injury, okay? When you look at these old scans, you sometimes see a bright spot on the vermis. Just have a look at the second picture where the arrow is, okay? Okay, it's a known thing, okay? When you look on the sagittal image, you see some atrophy on those lobules, those anterior vermian lobules, okay? So we found 20% of children had cerebellar injury, okay? A lot of it vermian. The literature talks about 5 to 20%. Why have I found almost double the cerebellar injury when it's supposed to protect the posterior fossa, you know, your blood supply? Why is the posterior fossa involved? So I think they have underestimated it, and what we show is the truth, okay, that it's almost double. It's a fifth of children with hypoxic injury have cerebellar injury. I think the DWI has technical limitations in the posterior fossa. Some of this could be post-synaptic injury, but in fact, post-synaptic injury, I will show you the circuit should involve the dentate nucleus, not the vermis. And of course, when they do biopsy specimens on the few patients that die, we know there's Purkinje cells. The Purkinje cells are susceptible, and they die from profound injury. And we found that 50% of these vermian injuries were in the BGT. So I'm just telling you now, the cerebellum is a primary injury site. The vermis happens with the rest of BGT. So it should be BGTV, BGT vermis, and perirolandic, if you like. And the circuit, if it was circuit injury, it would involve the dentate nucleus. That's what I believe. Okay. Catastrophic injury. These are just areas of cystic change in a watershed. Okay. This is multicystic encephalomalacia. You will see that when you have watershed injury, things shrink. But when you have this catastrophic injury, the cortical, thin cortical rim is bulging. Somehow there's lots of water trapped. And the important part is that those areas are separated by little strands. So you need to window and look at your T2 and find them. These are glial strands. It's important for you when you look at a big bag of water in the head and you're doing it at age whatever, that you don't go and call this holoprosencephaly or huge hydranencephaly or big schizencephalic cleft. You need to find the glial strands, these strands that separate the sacs of water, because gliosis happens late in gestation, like after 34 weeks. So if you have glial strands, this wasn't an early in utero event. So you don't want to call it something else. You want to call this multicystic encephalomalacia from hypoxia. You don't want to call this hydranencephaly. That's the important lesson for me. There are some things we found, but I'm going to ignore them. And lastly, I know I told you the first thing I showed you, it's got to be bilateral and symmetric. Okay? But now that I've shown you some patterns of hypoxia that sort of beat that, I want to show you that it's not always bilateral and symmetric. So about 9% of cases are bilateral symmetric, but not the same amount, okay? Some are asymmetric, about 4% are asymmetric, I will show you that. And less than 1% is unilateral. Here's a unilateral case. Just one side had a watershed injury. Here's a case where it's asymmetric. You see the putamen on one side, but not on the other side. You see the thalami. And this is bilateral, symmetric, but not the same volume, right? The left hemisphere worse than the right. This happens, people, but as long as you know your patterns, you're in business. Last slide, I promise you can eat those sandwiches immediately. Okay, the lesson. The delayed MRI can show you the full picture. Everything that happened and everything that's permanent, now you can match it to what you see in the wheelchair. That's the important part. The primary injury and the secondary injury, right? You can diagnose for all those children in cerebral palsy clinic. For me, The importance is we give him a diagnosis. You know, it's for the second child, that it's not a metabolic disorder, that it's actually hypoxia. They can go to court. Somebody needs to be responsible for obstetric services. I'm not saying they must win, and I'm not saying someone is to blame. They must just go to court and find out. The Uli-Gyra is very important in the medical legal. Just remember the thalami, how differently they involve between the two patterns. And of course, we've shown lots of cerebellar injury we didn't expect. That's it. Thank you.